Good morning, everyone. My name is Thomas Ohara. I'm a general surgery resident at Eisenhower Army Medical Center in Augusta, Georgia, and I'm here today to talk about improved outcomes for our trauma patients in an MTF after initiation of an ACS verified trauma program. We have no disclosures for this presentation. So for background here, we have data that shows designated trauma hospitals have a documented ability to improve patient outcomes and patient survival compared to non-verified hospitals that treat trauma patients. DHA, or the Defense Health Agency, mandated that all MTFs become verified trauma centers to the level of their resources available in the year 2017. So in 2017, towards the end of the year, our institution did just that with the goal of becoming an ACS accredited level 3 trauma center based on our current capabilities. An important background here is that not only is this beneficial to the military, but our local community. We are located in Augusta, Georgia, which is a generally medically underserved population, and we're on the border of South Carolina, which also is a medically underserved population. We only have 2 ACS verified trauma centers within a 50-mile radius of our institution. We have 1 level 2 hospital, doctor's hospital, and then we have 1 level 1 center, Augusta University Medical Center. So if we were to become verified, we'd become the 3rd verified trauma center within a 50-mile radius. So starting in 2017, we had many changes that were implemented at our institution. We established a trauma activation criteria so that we had clear guidelines for which patients we need level 1, level 2 activations for, as well as trauma consults versus internal ED trauma activations. We also had an established trauma admission policy with a focus of having patients with traumatic injuries that were admitted specifically to surgical services rather than non-surgical services such as family medicine and internal medicine. We established transfer agreements for patients who had injuries that we could not care for currently in our institution, such as brain injuries that required neurosurgical evaluation with our local trauma centers. We also have 35 active trauma standards of practice. We instituted a program that we had the formation of specific trauma program leadership positions such as a trauma director and a trauma program coordinator to ensure that we're meeting our goals that would lead us to ACS verification and that we could fix any problems as they arose. We also instituted multiple interdisciplinary reviews for patient safety data, and we created an active trauma data registry, which did not previously exist at our institution, with reports delivered to appropriate state institutions as well as the National Trauma Database, the Joint Trauma Service, and DHA. So our study was a retrospective review of outcome data from our single MTF from 2018, when we had a full year worth of data, to the present. Our outcomes are based on metrics that are used for ACS verification, such as the emergency room length of stay, rate of admission to non-surgical services, the overall injury severity score of our patients, diversion rates, and time to the operating room. And our statistical analyses were performed as appropriately with student t-tests or ANOVA. So first, looking at our emergency department length of stay, we saw a statistically significant improvement in time of stay to ultimate disposition, whether that was from ED to admission, whether to the floor of the ICU, to the operating room, or to the interventional radiology suite, transferred to another hospital, or ultimately death if the patient died in the emergency room. You can see here that we had a statistically significant improvement from 2018 to 2019 and from 2018 to 2020. However, while trending towards significance, we had an improvement, but not a statistically significant difference in 2021. This may be contributed to the fact that in 2021, our institution was particularly affected by the COVID-19 pandemic with a significant lack of beds for large portions of the year. We also saw a statistically significant improvement in our rate of admission to non-surgical services. So in the first year of our initiation of our trauma protocols, we had a rate of admission to non-surgical services that was greater than 50%. That improved in every subsequent year with a p-value of less than 0.01. While we were improving these trauma metrics, we also saw an overall increase in our injury severity score over time. So while there's no statistically significant difference in the overall injury complex of our patients from 2018 to 2019, in the years 2020 and 2021, we saw a statistically significant increase and our overall severity score for our patients, suggesting that our institution is taking care of sicker and more injured patients while simultaneously improving our trauma metrics. That also shows that we have an increase in the overall number of patients with significantly higher ISSs. Another metric that we looked at was diversion time. This was specifically for trauma diversion time. So for the inability for us to take care of our patients in the emergency department and resuscitate them and then place them to an appropriate disposition. In 2018, we don't have a specific number for hours or a total time that was spent on divert, but we spent a greater than 5%, which is one of the markers that the ACS uses to verify on divert. That improved over time from 2.6 to 1.8, ultimately to 0 hours spent on divert in the year 2021. Lastly, one of the metrics that we wanted to evaluate was time to the operating room for emergent trauma procedures. Unfortunately, we did not have a very significant number of patients over the 4 years evaluated that needed emergent trauma surgical intervention or emergent IR intervention. But you can see here, compared to our time to the operating room for acute care surgery for patients who needed surgery for non-traumatic injuries or non-traumatic disease processes, we do have an improvement in overall time after instituting our trauma protocols. Some of the limitations of this study are the retrospective nature of it, as well as our small sample size for certain data points such as time to the operating room. And it also does not include our patient outcome data such as overall length of stay or 30-day mortality, which we would like to evaluate in further studies. In conclusion, the establishment of a trauma program at our institution, in accordance with the American College of Surgeons guidelines for verification, improved our overall trauma metrics for patients at our institution. Future directions that we'd like to go with this data is to look at additional variables such as time to CAT scan for patients who presented with trauma activations. We'd like to analyze the data specifically based on level of activation, so patients who presented as level 1 versus level 2 traumas versus our trauma consult patients, and then look at long-term patient outcomes based on their injury complex at presentation, their injury severity score, the mechanism of their injury, and then the level of activation. These are our references. Thank you for your time, and I'm happy to take any questions at this time.